We're live in 5,
4, 3,
2,
1.
Great. Good morning, everybody. Welcome to this edition of the Virtual Spine Journal Club. Today is December 5th, 2025, and we are very proud and interested and looking forward to this journal club. And it's going to be led by Dr. Freyvert from the Department of Neurosurgery from Houston, Texas, and he has assembled a couple of interesting articles. Yev, are you there?
Yeah, absolutely.
Great. Super to see you. Looking great. And he's at Houston Methodist. He's in a short while done a great job and made a name for himself with some cutting-edge research, and he's already a very sought-after spine surgeon and neurosurgical colleague in Houston. What are we going to talk about today, Yev? Give us a little outline.
Yeah, we're going to discuss the conservative management of radiculopathy. It's, I think, very important for for surgeons to be abreast of that kind of literature. We're the last line of defense in many cases.
That's really, really pertinent. Before we pass the microphone over to him, literally and figuratively, just want a quick shout out. Tomorrow is our robotics course. I think it's the 12th annual robotics course, December 6th with J. Pat Johnson and Dr. Strazen running the show, and a really cool occasion. So without much further ado, Dr. Freyvert, take over the helm and lead us through this interesting discussion.
Absolutely. Thanks for having us. It's great to be with you guys again. So as Dr. Chapman mentioned, I'm Yev Freyvert. I'm a complex spine surgeon here at Houston Methodist, and I'm joined by my colleague Sean Barber, who's a spinal oncologist, as well as a panel, of course, of our excellent residents and fellows. I'll keep this very brief because we have quite a few good papers to discuss. The fundamental reality is that most patients who we see want to avoid surgery whenever possible when coming in for spinal concerns, including radiculopathy. And as surgeons, we are the last line of defense for these patients. And sometimes the armamentarium at our disposal to keep patients out of the OR is, or at least feels, pretty limited. So to that end, I think it's very important to stay abreast of the latest developments in terms of what our options actually are. So we've selected some recent literature with an emphasis on multiple study types, multiple treatment modalities, and also a little bit of an international perspective. So with that, I'll ask Zaru to start the presentation for us with a couple international studies focusing on physical therapy and analogous treatments.
Sure thing. Thank you very much for the invite. My name is Zaru Asfau. I'm a PGY1 at the Methodist. So today I'll be talking about conservative management around lumbar radiculopathy. The first paper comes out of Iran. It's titled Combined Aquatic and Pilates Exercise to Improve Pain, Mobility, and Functional Disability, and specifically women with lumbar disc herniation. The population of focus are women with mild to moderate lumbar disc herniation. The total sample size was 45. The intervention was aquatic or combined aquatics and Pilates exercise programs. The comparison group was a group that was just allowed to do routine daily activities without any structured exercise regimen. And the outcomes of focus include improvement in pain based on the visual numeric scale, mobility based on the modified Schober test, the quality of life based on the SF36 health survey, and functional disability based on the ODI. In terms of methods, the inclusion criteria included women who are not pregnant, aged between 30 to 50 years old, and had an MRI finding that demonstrated mild to moderate lumbar disc herniation, and no indication for surgical intervention per an orthopedic specialist. Another important inclusion criteria here was that they had no prior history of surgery. Each exercise intervention group had 8 weeks of this intervention of 3 supervised sessions per week. Each session included a 10-minute warm-up followed by 45 minutes of a structured exercise regimen and a final 5 minutes of cool-down exercises. Participants in this study were allowed to take over-the-counter NSAIDs as usual. In terms of the demographic characteristics of the subjects involved in this program, in this controlled trial, the investigators were quite successful in recruiting subjects that had no statistically significant difference in terms of their age, height, weight, BMI, and the disease duration. If I had to bring your focus up to the disease duration, some of these patients had around like 2.8 years, 3.4, 3.3 years with this lumbar disc herniation going on. In terms of the main results, in terms of resting pain, the control group had a higher pain assessment as compared to those in the aquatic and the aquatic exercise plus Pilates group. In terms of activity pain as well, the control group had a higher pain score. In terms of mobility, the intervention groups had better mobility, as well as the functional disability score was lower in that group. And finally, in terms of quality of life, the subjects involved in the intervention groups had a better quality of life at the end. So across all outcomes, there was a statistically significant difference in those who underwent the intervention exercise pathway as compared to just continuing routine daily lives. However, there was no significant difference between the control group and just the aquatic exercise only group based on mobility and ODI. And there was no significant difference between the exercise groups, just the intervention groups in terms of pain. So for the conclusion of this paper, what we could draw from the findings is that combined aquatic and Pilates exercises are effective in improving pain, mobility, functional disability, and quality of life, specifically in women with lumbar disc herniation. If we had to zone in on the aquatic exercise component, it offers benefits specifically for pain relief function, while Pilates is highly ranked for both pain and disability improvement. Another major caveat to this study is that the Pilates component was less robust when it comes to pain, when it comes to disability rather than pain. In terms of limitations for this study, it's a small sample size, 45, 15 across all three arms. The generalizability of the findings might be limited to women in a specific clinical setting, and also like specific age range between 30 to 50 years old. That brings with risk of selection bias. However, it's quite a neat design in terms of the way they managed to recruit patients from a specific area, as well as the way they had a high retention rate across the study period. So this study was from Iran. The next one is from Pakistan. So this one was focused on the effects of non-surgical decompression therapy in addition to routine PT for improving lumbar radiculopathy. The patients in this study were adults with lumbar radiculopathy. The sample size was slightly higher, 60 subjects. The intervention group was subjects who underwent non-surgical spinal decompression therapy plus routine PT. And the comparison group was routine PT. And in terms of outcomes, sort of similar outcomes. However, this one included the back extensor muscle endurance using the prone isometric chest raise as a quantifiable method to assess for this outcome. Improvement in pain, they used the visual analog scale, which is quite slightly different from the visual numeric scale. They used the same modified Schober test for mobility, the SF-36 health survey for quality of life, and the respiratory disability index for functional disability. In terms of their methods, inclusion criteria included all adults that are not pregnant between 25 to 55 years old. They had lumbar radiculopathy that was diagnosed by a neurosurgeon in this case, based on MRI and X-ray findings. They had at least 3 weeks of lumbar radiculopathy, as well as no prior history of lumbar surgery or other lumbar pathology, which included tumors and etc. Each group in this study had 4 weeks of intervention, which consisted of 12 sessions in total. And the control group had to undergo routine PT exercises plus TENS. And the intervention group had to undergo the same interventions plus non-surgical decompression using this spine MT device. In terms of the results, they had the experimental group had better outcome in terms of back pain intensity, functional disability, the buck muscle endurance, as well as range of motion, both for flexion and extension. However, for quality of life, the domains that were statistically significant as compared to the control group were quality of life pertinent to role limitation because of pain and bodily pain. in terms of conclusion we could draw from this study, we could conclude that adding non-surgical spine decompression therapy to routine PT tends to yield greater improvements in pain, lumbar range of motion, endurance of back muscle, functional disability, as well as in terms of the role of quality of life, as well as just overall quality of life that the patients might benefit from undergoing this intervention. However, it's within medium to large effect size within a 4 weeks of treatment period. So maybe this is food for thought, and also a potential to explore non-surgical spine decompression as an adjunct to current PT for short-term improvements. Limitations include a short follow-up period of just 4 weeks. So we're not certain in terms of long-term efficacy and durability of the benefits of this intervention. It's a small sample size. It's a single center. And the literature has quite weak or conflicting evidence when it comes to long-term outcomes of non-surgical spine decompression. Thank you very much for the invite, and I hope you got something out of this presentation. Thank you very much.
Zara, let me ask you, that second study especially, it focused specifically on the Spine MT device. Do you know if any of the study's authors were involved with development of that device, or if they had any conflicts of interest?
I'm not aware. They didn't disclose any like conflict of interest of anything of that sort in terms of that device, but it has quite a good international footprint based on what I looked up for that device.
Yeah, I've heard of it myself. It just, you're early in your career, and that's something that's always important to emphasize when you have a study looking at a specific, very specific device or very specific pharmaceutical. You want to make sure that there's no conflict of interest. Let me ask my colleague Dr. Barber or Dr. Chapman. My perspective is that the U.S. is considered a little bit scalpel happy compared to many other countries. Do you have the feeling that, say, compared to potentially more resource limited areas, that's true? Do you think we're the stereotype regarding us is that we're a little bit more eager to jump towards surgery?
Who do you want to go first? Dr. Barber, do you want to go first?
Sure. Well, we have in residency spent some time in London working in the NHS, and I can say, comparing those two health systems, the US is, I think, a little bit more likely to recommend surgical intervention, sometimes for conditions that could be treated probably adequately with, non-surgical therapy. I think wouldn't say we're, trigger happy, but maybe more our patient population. Also, I think physicians may be more apt to kind of jump towards surgical intervention a little bit sooner compared to what I saw just in 6 months in London, but that's sort of anecdotal.
I think that's a great perspective, Dr. Barber. So this is Jens Chapman in Seattle, and thank you for participating in this. And this is a really cool topic. Just on a general perspective, non-operative care costs, and that includes everything, are probably about 40-fold higher than all spine surgical costs. So just on a quantum basis, this is a completely different dimension. And those are numbers from Joe Cheng, so I'm not making those up, from probably about a decade ago now. Now, the answer to Dr. Freyvert's question of are we more trigger happy is a simple one. It's the old legal answer of it depends. And sadly, we have a couple of things to contend with. That has to do with insurance status, that has to do with race, and basically expectations of patients. Those are factors that are pretty significant. And one new variable that has occurred is that under the premise of less invasive surgery, the appeal of the population to seek a quick, little, quote, painless intervention to alleviate themselves from their major pains has become far more prevalent in those who practice that. So I'm not calling it dark art, but it's a variant of treatment. So this is a difficult subject to broach because it touches upon societal expectations and has a lot of complexity to it. In general, I think all of our professional societies, and that goes for neurosurgeons as well as orthopedic surgeons, we pursue a pretty clear strategy of education towards surgical interventions. And those are basically the trifecta of unrelenting pain over a certain period X, usually more than 3 weeks, and failure of non-operative care and progression of neurologic symptoms. And then finally, significant functional neurologic loss. Magnitude of the disc herniation over 70% canal compromise is probably also an accepted form of an early intervention indication. But again, what happens in the field is different, and the variables I discussed are there. I have a question for Dr. Asfa. So about the water, what is it in the water that makes it so appealing? What did the authors speculate might help get patients with radiculopathies get better?
Yeah, they attributed just aquatic exercises tend to be beneficial in terms of unloading weight as compared to just working on flat surfaces. It tends to provide like less resistance on the joints, and in terms of weight bearing, it tends to confer them some advantage. So that's what they said in terms of the aquatic components. For the Pilates, they mentioned sort of something similar, but it was more focused on the core strength. It is quite beneficial in terms of developing the core strength of the participants.
So these are, I think, very insightful statements. The key thing from my perspective, and I'll pass off to Dr. Freyvert again then, is getting radiculopathy patients to start moving again. So getting over the intrinsic pain pathway signaling in the amygdala and getting them to move to try to get those inflamed nerve roots to de-inflame, more or less, deflame. That's not a good word, but that's the magic. In water, if it offloads it, or decompression, those are very reasonable initial strategies. But getting into that confidence level that motion is actually not going to just destroy the patient pain-wise is the magic, aside from pharmacology. How standardized were the treatments in terms of pharmacologic management? How standardized were they in terms of, or how consistent were the outcomes and the demographics in terms of surgical conversion? Do you have any data on that?
Unfortunately, they didn't comment on that. They didn't comment if any of the participants ended up proceeding to a surgical intervention down the line.
The largest prospective study that I'm aware of in the US, and this is dating myself, came actually here from Seattle, from the Kaiser, the precursor of Kaiser, which was called Group Health at the time. I think the first author was Sharkey, but don't quote me on that, or Sharkey, something like that. And they had a very large formal PT versus handout protocol for group health patients. That's again a collective patient group that's basically tied to that insurance carrier and their treatment. And there was no difference between formal PT and between a self-directed exercise program based on a handout. The logistical problem in our country is that having pool therapy has become prohibitively expensive for therapists because it adds a whole another level of insurance coverage that is not reimbursed. And these traction tables in the US, as much as they're professionally kind of controlled, are extremely expensive. They're usually run in PT offices that are cash pay, or they run in chiropractic offices, again, a cash business. So those are my two comments on that. But yeah, I appreciate both articles. And again, they tell me something that for us as practitioners is the key thing towards successful non-operative measures. That's getting patients to move again.
Yeah, absolutely. Before we move on to the next article, just one more quick comment. With respect to aquatics, what Dr. Chapman mentions and what Zaru mentioned in terms of being able to offload the joints and offload the stress from other portions of the skeleton is incredibly important. Many of these patients have degenerative disease affecting the knees, the hips kind of concurrently. And if we want to get them to move to begin that disinflammation process, getting them in the water is often a really good idea. But I don't know what your experience has been, even in the middle of a major metropolitan area. Sometimes access to, or for financial reasons, getting patients to aquatic therapy is just very difficult. So always a consideration. Let's move on to Sam, our research fellow. He's going to talk about another kind of core pillar of treatment for radiculopathy. Sam, you may be on mute.
Yes. Can you guys see my screen?
Yes,
Okay. Okay, so I will be talking about Thank you thank you, Dr. Freyvert, for inviting me to talk about this comprehensive review. So the title of the paper was The Effectiveness of Lumbar Transforaminal Injection of Steroids for Treatment of Radicular Pain. It was a comprehensive review published by Smith et al. From Columbia University. So just to give a background, many studies have shown that patients with radicular pain actually have higher neuroinflammatory markers in the neuroforaminal and the spinal cord. So epidural steroid injections is one of the mainstay therapeutic strategies for radicular back pain. And I know most spine surgeons and most even brain surgeons will tell you, if you come with a back pain, they will recommend medical therapy prior before, recommending anything close to surgery. So regarding the epidural steroid injections, the efficacy of many different approaches have been assessed. There have been many modalities that are used to achieve these injections, like the caudal, intralaminal, and transforaminal. And so what the authors sought to determine was the effectiveness of the lumbar transforaminal ESI, specifically for lumbar radicular pain. Just to give a visual representation of how these approaches are made, you can see that the transforaminal approach kind of goes into the neural foraminal through a little bit between the transverse processes of the adjacent vertebra. And the interlaminar approach uses a little bit of the interlaminal below the spinous process, and the caudal approach kind of use the sacral hiatus as the main corridor to doing these injections. But interestingly, even with the different approaches, there are, as I mentioned, there are different modalities that are used to achieve these epidural injections. And so with the transforaminal, there is the conventional one that is a safe triangular approach that uses the safe triangle, and a fluoroscopic imaging showing that, how the niggle is angulated into the neuroforaminal canal. The posterolateral approach actually uses the posterior lateral angle. And here, looking at these two needles, you would see that the posterior lateral approach comes a little bit below the conventional approach for injecting the steroid into the epidural space, and fluoroscopic image showing the angulation of the needle in this regard. Some surgeons also, or some treating physicians also prefer to use the Kemben triangle approach, essentially going through the Kemben triangle to reach to the nerve roots to do this type of injections. So the objective of the study was to provide an update to a prior systematic review that was published by McVicker et al. And they wanted to provide, practicing physicians with information critical to understanding, some, important factors like, indications, risk, safety precautions, and the expected benefits of this procedure for lumbar radicular pain. It was a literature review. They considered different types of studies, observational, pragmatic, and RCTs. What they initially did was to kind of categorize the different studies based on etiology. So categorizing studies based on disc herniation, spinal stenosis, and other pathologies. They try to accept studies that demonstrated whether an intervention was more effective than an alternative intervention, and also studies that provided important information on the effectiveness of the intervention, like a prospective study would do. And they use for reviewers who have been practicing this type of injections to actually assess the quality of the studies they included in their literature review. So they assessed based on these 3 points here, like how adequate was the study in terms of representation of clinical relevant data, whether the study had adequate representation of procedural techniques, study methodology, and data analysis, and if the study actually reported any complications with this with the lumbar transforaminal ESI. And just to add another layer of assessing the quality of these studies, they also use the grade framework, that's the grading of recommendation, assessment, development, and evaluation framework, to again assess the quality of the studies, to include in their literature review. One thing that they did was to structure their results based on these two main points, like treatment success rate reported in the individual, explanatory, pragmatic, and observational studies. And they categorized the results based on etiology. They also looked at, the study-defined definitions of treatment success compared to 50% reduction in the definition of treatment success that is stratified by the design. And essentially, they just paid attention to what the studies reported in terms of the therapeutic effects of this procedure with ODIs and pain scores, and with pain scales with VAS, NRS, NPRS, and other assessment tools. So with regards to the results for radicular pain due to dyskinesia, about 13 observational studies were included, 8 pragmatic studies were included, and 2 RCTs were included. On your right side is the different time points that treatment success were evaluated. And I try to give a window of the treatment success rate with this type of injections. What I want you to pay attention to is with the number of studies that actually reported treatment success with the transforaminal ESI, you could see the majority of the studies reported, somewhere between 50 to 60% treatment success rate with this procedure in the observational studies, and only very few studies reported treatment success rate that was above 80% or between 71 to 80%. With the pragmatic studies, even this rate, the treatment success rate, kind of was a little bit distributional to the studies that reported treatment success. We could see that the range was between 50% to 60% and between 61% to 80%. However, when it comes to the 2 RCTs that are included in their results, they saw that one study actually reported very less treatment success rate with the transforaminal ESI, and the other RCT actually assessed patients 12 months after injections and saw that patients were having a treatment success rate of about 80%. When they assessed the quality of these studies, they graded all these included studies as high grading, suggesting that the results could be reliable and more evidence-based. With regards to radiculopathy due to spinal stenosis, most of the studies reported treatment success rate that was either below 50% or between 50% to 60%. They had only 2 pragmatic studies that reported treatment success rate between 50% to 60%. And this was quite similar to the findings that they saw for the radiculopathy or radicular pain due to other diagnoses, with observational studies reporting treatment success below 50%. And with radicular pain due to spinal stenosis and other diagnoses, when they graded the studies that they included to come up with these findings, they realized that the evidence was low. Here on this particular slide, I just wanted to kind of give a summary of whatever I've talked about in the 2 prior slides. When we look at this part of the presentation, you would see that treatment success for radicular pain due to dyskinesia were actually better compared to treatment success with for spinal stenosis. So essentially saying that transforaminal ESI is helping patients with dyskinesia more compared to patients with spinal stenosis. The authors also assessed the studies to understand whether there was a difference between injecting particulate steroids or injecting non-particulate steroids, and saw that 4 studies reported equal efficacy between non-particulate and particulate steroids. They saw that only 1 study reported particulate steroids being better than non-particulate steroids, and 1 study was excluded because of poor quality of the study findings. What the authors then did was to assess the evidence for risk of the transforaminal ESI. They checked about the dosing that were reported in these different studies and saw that it was inconclusive data in terms of the right dosing. And so giving high dose steroids didn't really improve pain scores or didn't really help with disability compared to lower doses or vice versa. Similarly, they saw that with predictors of success of the ESI, the transforaminal ESI, the findings were very varied. Some studies reported that the longer duration of pain symptoms before injecting the transforaminal ESI into the disc herniation may be associated with poorer outcomes, whilst other studies show that early response to the injections were able to predict longer duration of the effect of the steroid use on this particular approach. They also saw that lower grade of the nerve compression was associated with higher success rate of these injections, actually reducing the patient's pain compared to higher grading of nerve compressions. They reported on new studies that are coming out with using different radiographic and imaging being a predictive factor or model for the success of these treatments. What the authors then did was to look at the surgery sparing effect of the transforaminal ESI and assessing the studies that included. They saw some consistency in the data showing that this approach actually lower surgery rates, but still there was a little bit of heterogeneity in the evidence that they found. Some studies show that at a follow-up of 13 to 24 months, ESI was able to reduce the rate of surgery. And multiple studies also show that avoidance of surgery could be between 56% to 90% using this procedure at 1 year, or between 67% and 68% surgery. So you could avoid early surgery, but could not prevent it. That essentially saying that the treatment have a little bit of surgery sparing effect with here. Finally, the authors looked about complications in the different studies that they included. And generally, they saw that transforaminal ESI was safe. It had minimal complications, but one of the complications that the authors found was a little bit high risk was a spinal cord infarction. And they saw that most of the studies that included particulate steroids actually saw this complication and explain the pathogenesis in a way that when the particulate steroids get into the bloodstream or that the vessel causes this embolic agglutination of the red blood cells leading to spinal cord infarction. But when they assessed the studies that they included to synthesize these results, they saw that the evidence was very, very low, suggesting that it could be reliable, but very less reliable. And there's always more room for more evidence to kind of like support these findings that they included in their results section here. So discussion. One thing that they discussed in their study was that using this particular approach was not a placebo. They saw that it has, significant lasting benefit over sham therapy, especially for radicular pain due to disc herniation. The quality of the evidence, they rated as low for, the effectiveness of this approach for spinal stenosis or different pathologies like epidural lipomatosis. They saw that the evidence was suggesting towards a better surgery sparing effect of this approach, but recommended further studies to help support this finding. With the duration of relief for this approach, the results was a little bit variable. Some treatments say like patients get better response to the ESI between about 3 to 6 months. But some other studies also said, the benefit can even go 1 year or 2 years post injection, but definitely varied in terms of the reporting. When it comes to specifically to disc herniation, they saw that the lumbar transforaminal ESI of the non-particulate steroids were equally effective as the particulate steroids. But they did warn that if surgeons or clinicians who do these types of injections would use the particulate steroids, they should be mindful of spinal cord infarction. They warn strictly about physicians avoiding the use of dexamethasone plus ropivacaine together because of the risk of spinal cord infarctions. With limitations, again, even though they did a very comprehensive assessment of the studies that they included in their review, they still talked about a methodological limitation in a sense that because some of these patients get multiple injections in their over time, they saw this was a challenge in interpreting the true durability of the effect of an individual transforaminal ESI. They also talked about maybe being a little bit more parsimonious, using the 4 reviewers to kind of like fish out other studies that could probably had added a little bit of more data to their results. So in conclusion, the authors suggested that lumbar transforaminal ESI is an effective treatment for radicular pain, particularly due to disc herniation. But when it comes to spinal stenosis or other pathologies, there was a lack of high quality evidence demonstrating the effectiveness of this approach. They also saw that the published data currently in the literature demonstrated that the lumbar transforaminal approach with particulate steroid is not inferior to the non-particulate. The non-particulate steroid is not inferior to the particulate steroids. And then they recommended that if physicians would do this type of injections, then they should do the non-particulate steroids as first line because of the enhanced safety profile. Yeah. I think this was the conclusion of the study. Thank you.
Thank you, Sam, for that very thorough review of the paper. I think this is a really important topic. Epidural steroid injections are something that we frequently utilize in our patient population for treating radicular pain. I think one question patients often have is how long is this going to help, or what's the likelihood of it helping? So this paper serves to answer some of those questions to some degree. I wonder if you have any thoughts as to why epidural steroid injection would be more beneficial in radiculopathy due to disc herniation when compared with patients having radiculopathy due to like degenerative stenosis.
Well, based on the evidence that they actually synthesized from their review, they saw that because the needle is going into the disc space and just exactly to where the herniations are, maybe the injections are able to decrease the neuroinflammation at the region and causing better response compared to spinal stenosis. But certainly there could be other predictors that could influence this positive treatment outcome compared to spinal stenosis.
Yeah, I wonder if disc herniation being kind of an acute process maybe has more inflammation in the vicinity, and that's a steroid anti-inflammatory maybe have a better effect, although that's theoretical. But these injections can be useful for therapy, obviously make the patient feel better. Another reason we use them sometimes is for diagnostic purposes, if we want to verify that the pain generator is indeed the spot that we think it is prior to considering surgery. So that's something that this paper does not talk about, but another kind of reason that can be beneficial in our patients. I wonder, Dr. Freyvert, Dr. Chapman, what's your kind of experience and what's your usual workflow with epidural steroid injections? Do you use them in your practice, or?
Absolutely. That's a critical point. These days, many patients will initially decline injections of any kind because there's this perception circulating in the community that the injections are just a band-aid. But what I often emphasize with my patients is that yes, the effect may be temporary, but the diagnostic benefit is incredibly valuable, especially in complex cases where the pain generator isn't necessarily clear. That's an absolutely critical point.
Yeah, let me add to that. So again, great paper. I think Dr. Kamkam and Dr. Barra agree with your statements. I will again quote an old paper, the old guy here in the room. So I think it was 2014. It's a friend of mine, Jana Friedley. She's a physiatrist who does not perform injections. She performed a prospectively randomized trial at UW with 400 patients. I just looked up the numbers, so I don't remember that, but it was sizable. And it was published in New England Journal of Medicine. And this is actually a study that changed our practices, because ever since then we have to fight for insurance companies for injections nowadays. And it's us, the surgeons, who have to kind of be the heavies and the patient advocates, which is a proud and cool thing to do. But basically, there are several components to that study, but one key one was that it didn't matter if you had steroids or just local anesthetic. And basically only 2/3 of patients responded, and only 1/3 of patients had a response over a period of, I think, 3 weeks, but I didn't look at that detail right now. But it's cast a very difficult picture on epidural steroids and transforaminal epidural steroids specifically. The key point that we learned from this, however, was that the operator seemed to matter. And what we learned from these studies are always interesting. Sometimes we learn things that we did not know before. So it seems that operators who document the quality of their transforaminal injection with an epidurogram have a higher success rate. That was an unofficial, non-published thing. And you just don't know what the quality of the injector was. We assume that an injection is like a pill, like a red pill versus a blue pill or something like that. No political statement inferred. But what really matters is how good the operator is, just like in surgery. And that's the thing that when we do these PRCTs, we can't really quantify. So the learning point there was that if you do a transforaminal injection, you should probably have an injector to document where they were right through an epidural injection, and then they should have a patient diary that the patients fill out available for us, the treating doctors, so we know whether they had an anesthetic effect versus that famous transition zone of 24 hours to 36 hours when the steroids are supposed to work. The use of steroids is a really big deal, and Randy Davis, our good friend, is just pointing in, based on this study insight, insurance companies now actually demand that injection specialists have a contrast there. So this study by Jana Friedley actually changed practices. It made it harder for us to get authorization, and they demand that. I always look for a fluoro shot to see whether that was actually done, and I'm always curious where that needle actually is and whether it's actually the segment that I had targeted and specifically asked for, or whether the interpretation of the injection specialist was something different. One little side note, the vascular thing, I thought this is not possible in the lumbar spine, but a patient of mine with an L12 foraminal injection that I never authorized or ordered actually got a conus medullaris syndrome from a particulate matter, artery of Adam Kiewicz embolization. So I've actually seen that, and there's multiple images before and after that show that this patient actually developed a conus medullaris syndrome from a flipping L12 radicular artery injection. So it can happen in the lumbar spine also. But great paper, great discussion points.
Thankfully, a very rare complication. Let's move on to Dr. Farrell, who's one of our senior residents, and he's going to discuss another critical mainstay in the treatment of radiculopathy.
All right. Hello, everyone. Let me share my screen here. Let's see. Can everyone see my screen? Great.
Yes, now if you go into presenter mode.
Start. Okay. Let me minimize this here. All right, I'm Ryan Farrell. I'm one of the fourth-year residents here at Houston Methodist, and thank you for having me on today. And the title of my paper is Risk of Dementia Following Gabapentin Prescription in Chronic Low Back Pain Patients. And let's see here. And for background, gabapentin was approved by the FDA in 1993 for the treatment of partial seizures. And it's been used increasingly, more recently, particularly the last 20 years for the treatment of chronic pain. It has a known low abuse potential, and given the context of the more recent opiate crisis, there's been more interest in medications like gabapentin that can provide pain relief and that have offer a low abuse potential. And while the exact mechanism is not fully known, it does have a high affinity for voltage-gated calcium channels in the brain, and it has a net inhibitory effect on presynaptic transmission, part of the mechanism for its anti-epileptic effect, and also in the reduction of pain signaling. And the authors were also looked at pretty much all the available literature regarding the concern for gabapentin and if there is a link to any neurodegenerative process, including dementia or cognitive impairment. And it's rather interesting how mixed the literature is, and that there's a lot of positive studies and negative studies, and there really is no consensus at this time on this topic. And, the authors, they, for example, talked about a recent study from 2023, a matched cohort study that did find an increased risk of dementia in patients taking gabapentin, and found that a higher cumulative dose also was a risk factor. And interestingly, for their study, they found the risk was most pronounced in patients below 50. And then on the flip side, they also talked about a recent study from 2024 with over 200,000 chronic pain patients that found no increased risk of dementia or cognitive impairment, regardless of age, dosage, or gender. So it's kind of interesting how such different results can be found on this topic. But thinking kind of just generally, gabapentin has an anti-epileptic effect. It inhibits presynaptic transmission. And it has been found in some literature to reduce neurogenesis and synaptic plasticity in the memory-related brain regions. So, kind of thinking about it that way, I mean, there is some plausible mechanism going on here, and patients often relate feeling some cognitive fog and some effects that do seem to kind of make sense that this could be a process that's going on. And for this study, they analyzed electronic health records from 68 healthcare organizations in the USA, looking for, their target was just gabapentin prescriptions and the number thereof. And they were looking at this over a 10-year period following an index event, being a patient presenting with a new pain diagnosis, and then whether or not they were prescribed gabapentin or not. And let's see here. And their inclusion criteria was chronic pain syndrome, and particularly relevant for us, lumbar radiculopathy or chronic low back pain. And the timeline of the study was 2004 to 2014. And they excluded anyone who used gabapentin previously, already had a diagnosis of dementia or Alzheimer's or epilepsy, prior stroke or cancer, were excluded from the analysis. And they also, looked at patients, all the patients were above 18, and they also subdivided into like 18 to 34, 35 to 49, et cetera, to see if there was particular more pronounced effects in those ranges. And they had a pretty robust, stratification between the control group and the exposure group for different demographic variables or health-related type conditions among their patients. So they had 26,000 adults were analyzed with propensity score matching, and the endpoint being dementia or mild cognitive impairment within 10 years of their initial presenting pain diagnosis as the endpoint of the study. And for the results, they did find an overall increased risk of dementia and patients greater than 18 in the gabapentin cohort, and as well as patients, interesting, who aren't elderly, below 65. But they found that the association was stronger for more elderly patients. And, interestingly, the other study they were talking about found this was more pronounced in patients less than 50. Not unsurprisingly for them, though, they found that for the younger patients, 18 to 34, they did not find any statistically significant increased risk in the gabapentin group. And then for this chart, this was their endpoints and the risk ratios for the different age groups. And pretty much every group but the 18 to 34 had a statistically significant increased risk of dementia or cognitive impairment. And, even 35 to 49, there's a pretty, significant increased risk of mild cognitive impairment of, risk ratio of 3.5. And then they also looked at kind of more of a surrogate for cumulative dose. They grouped patients with gabapentin prescriptions of 3 to 11 over this time period, comparing those to patients who had 12 or more. And for most of the groups, they also had a further increased, statistically significant increased risk of dementia, except for the younger patients, though the 35 to 49 still had some increased risk, though, of mild cognitive impairment. So there also seems to be a pretty strong evidence for, in their study at least, that the cumulative dose seems to matter as well. So there, still this, it's an interesting study, but there's still just kind of, I think, just adds to the discussion that we really aren't sure exactly what the impact of this drug is here. Though, I mean, there is a plausible mechanism for the drug causing these effects and inhibiting neurogenesis, and just grossly how patients describe feeling on the medication. It does not seem unreasonable here that there's probably something there. And then some limitations of the study, mainly they couldn't really get the exact dose the patients took. They just had to use a surrogate, a marker as number of prescriptions, or they didn't really know exactly how long the patients were on the medication for. It was just, the number of prescriptions in this time period. And, thinking as neurosurgeons and, my practice in the future, how I would think about this study and this topic, I don't think it would really changed my practice too much, in the sense that gabapentin is quite useful for acute radiculopathy and getting patients to just help them cool off, and hopefully, they get resolution of their symptoms with time, or as a bridge to eventual surgery, and then kind of the immediate post-op period, and eventually getting them off the medication. We don't really want to have our patients on gabapentin for multiple years and just hold the course and not really understand why they're on it so much. But I do think this, I wasn't aware that this was a potential effect of gabapentin increasing dementia risk. So for example, if you have a patient who's pretty much pain-free, has been doing well, you've been following them, and maybe they're post-op and they've radiculopathy's resolved, but they just feel like they've done well on gabapentin, so they keep taking it. I think that'd be pretty good, patient population to just try to stop the medication, given that, it's not a proven risk, but there is some evidence out there that it could cause this effect. And just, thinking logically about it, there's a plausible mechanism. And, if the patient doesn't need it, it might be good motivation to help try to get them off of it. And yeah, so it was a pretty quick paper, but any questions? I thought that was a pretty interesting topic.
Thanks, Ryan. That was a good discussion. Yeah, in recent years, especially with all of the emphasis on taking people off opioids, given the opioid crisis, we've been leaning more and more heavily on alternative options, which certainly include gabapentin. And I'll freely admit I don't regularly counsel patients on the risk of dementia, especially with long-term use. But certainly this is food for thought. I think in the interest of time, we should probably move on to our orthopedic fellow, Hans, to bring us home. He'll be presenting a study actually looking at one aspect of the outcomes of surgical intervention. And I think this is very important because counseling is a major intervention that we provide as surgeons. So being well informed about what to expect with kind of fairly standard procedure, a microdiscectomy, and to tell patients what that entails is incredibly important as part of conservative management. So Hans, bring us home.
Yeah, of course. So my study, thank you, Dr. Freyvert, thank you, Dr. Barber, and hello, Dr. Chapman. So the study is titled Timelines and Associated Factors for Return to Work in Patients with Painful Radiculopathy, undergoing lumbar microdiscectomy, followed by physiotherapy, a prospective cohort study. This was published in July in the Spine Journal. It's a study done in the Netherlands. So we know that most patients improve pain rapidly after microdiscectomy, but returning to work is a more complex behavioral, social, and physical outcome and has been less studied prospectively. We know that work absenteeism after surgery can cause a socioeconomic burden. And in literature, we've seen that 5 to 22% of patients undergoing microdiscectomies do not return to work for about 2 years. This range is very wide, given that prior literature has analyzed mixed surgical techniques, has different retrospective designs, and there are very heterogeneous populations. Some of the contributors to poor return to work that the authors identified in past literature are high pre-op pain, disability levels, longer time to surgery, higher depression levels, occupational mental stress, less job satisfaction, lateral disc prolapse, duration of sick leave before surgery, and they identified that we have a need for clearer timelines and predictors to guide patient counseling. So moving on to the objectives, the primary aim of this study was to estimate the probability of returning to work in patients with painful lumbar radiculopathy undergoing microdiscectomy and followed by physiotherapy. And the secondary outcome was to identify the variables that may affect the return to work. Moving on to the methods, this was a prospective cohort trial with 257 patients that were followed for 52 weeks. They included patients that had a history and physical indicative of nerve root compression, MRI, and clinical findings of radiculopathy, and patients in paid employment. They excluded patients with tumors, fractures, cauda equina syndrome, prior laminectomies, pregnancy, and those who did not speak the Dutch language. The surgery was a microdiscectomy using a microscope, and they had a standardized physiotherapy protocol after surgery. In terms of analyzing the primary outcomes, the study has more stringent return to work definition than ones that are out there in spinal literature. They define full return to work as returning to work to the same employer, doing the same task with the same demands. No full return to work were patients that took longer than 52 weeks that returned to a different role with restrictions. They measured this via standardized questionnaires, and they analyzed using Kaplan-Meier survival curves and uni and multivariable Cox regression. Now, to observe the results and the patient characteristics, we see that the average age was about 43 years old. We see that 61% of patients were male. The most common levels were L5S1, L4, L5, and we see that the disability rate within their population was pretty increased in terms of the Rowland-Morris Disability Questionnaire. Now, moving on to the results of the primary objective, about 69% of patients were able to fully return to work by 52 weeks. The median return to work was 16 weeks, so about 4 months, with an interquartile range of 14 to 16 weeks. And of those patients that did return to work, most of them did by 26 weeks or 6.5 months. From the patients that did not return to work, 9% of them had moved to a less physical role, 11% of them had the same job but modified duties, and 6% of them changed their entire job description. Now, to look at the univariable predictors, a hazard ratio greater than 1 indicated a faster return to work. A hazard ratio less than 1 indicated a slower return to work. And we saw that a high level of education, self-employment, and less physical work were predictors of faster return to work. However, a higher disability was a predictor of slower return to work. Now, when adjusting for confounding variables, they saw that faster return to work was associated with a higher level of education, self-employment status, and absence of predominant physical activity. And slower return to work was associated with high disability scores. These are some Kaplan-Meier curves that highlight in the y-axis the probability of no return to work, and in the x-axis the variables that we have just discussed, including educational level, disability, employment status, and physical work demand. Then moving to the interpretations and takeaways. So the mean return to work was about 4 months. And we know that if the patients are going to return to work, they will by 6 months. It was interesting that age, sex, and pain before surgery really had no significant effect on the time it took to return to work. And some theories on the variables that they showed was that high disability may lead to a slower recovery, which may slower the return to work. Self-employment may give patients a financial incentive to return more quickly. And then a higher education may lead to better health literacy and less physically demanding jobs. Limitations on this study was that they really did not analyze psychological and depression variables. There was no workers' comp data. There was some heterogeneity in the physiotherapy intensity they received after surgery. And of course, that there were very strict return to work definitions. Now, in conclusion, 69% of patients returned to work by 1 year. The median was 16 weeks. It is important to identify at-risk patients, including those with lower education level, physically demanding jobs, and high disability scores. And then these results can help us set some expectations and individualize recovery and planning. Thank you very much.
Nice paper. We have to probably come to a close. Dr. Freyvert, Dr. Barber, do you want to complete our session?
Absolutely. Go ahead, Dr. Barber.
Well, no, in regards to that paper, thank you, Hans, for presenting. I think it's just kind of shocking to see how long it takes some of these people to return to work. You always imagine after a microdiscectomy, maybe 2 weeks you can go back, but this kind of shows that it's quite a bit longer. So something to consider. I think all these things are probably very important to consider when speaking to patients about the roles of non-surgical intervention, roles of surgical intervention, maybe with some of this evidence, reconsideration of the importance of non-surgical management and its value in patient care. That's kind of my overall takeaway.
Absolutely. I think both surgeons and patients may see surgery as a silver bullet, and these results kind of temper those expectations quite a bit. Excellent presentation, Hans. Thanks for having us. Always happy to be here, and thanks again.
Great topic, great job. Many thanks to our 4 presenting trainees. Really cool topics and compelling discussion points, and to be continued. But this definitely advanced our current date of knowledge, especially the last paper on gabapentin is certainly highly thought-provoking, but all of them were really cool. So we thank you from the side of the SSF, and for all those interested, tune in and what's cool and new in spine by Drs. J. Pat Johnson and by Danielle Drazen. Tomorrow, the 10th annual robotics course, Saturday, December 6th, and you can join us live, and whatever is latest and newest, you can see there. So with that in mind, let's have a good day and good weekend, and thank you, Yev, very much, and Sam. Take care.